Good afternoon to all. It's an honor really to be part of this great conference, and it's an honor also to introduce our highly experienced and respected speaker from Canada. She's going to cover basically the specific for nurses, the evidence-based conservative management of UI and guidelines for intermittent catheterization in collaboration with ICS. So I'll just give a very short brief of our colleague from Canada. She's actually, I think it's around 5 o'clock in the morning, 6 o'clock in the morning in Canada. So Miss Frankie Bates is graduated from the Royal Free Hospital in London, England, as a registered nurse in 1980s. She obtained her Nurse Continence Advisor certificate from Macmaster University, Hamilton, Ontario, in 1998, and received her pelvic floor physiotherapy certificate in 1999. Frankie co-manager also a urology wellness clinic in St. John's, New Brunswick. Her work involved assessing and treating urinary and fecal continence in children, adults, and frail elderly, as well as educating and treating patients with erectile dysfunction. She also led a clinical trial coordination in studies, both EDs, UI, for approximately 10 years. Frankie served also as education committee in the ICS, which is International Continence Society, presently serving as well her second term. Previously, Frankie served on the Continence Promotion Committee of the International Continence Society for 2 terms. She chaired and spoke in multiple public forums globally under the auspices of International Continence Society to increase awareness of UI to the general public. She also served on the board of directors of Canadian Continence Foundation, as well as the executive board for urology nurses in Canada, Canadian Nurse Continence Advisor Association for many years. So that's all really about our colleague. I'm sure she will have a really very fruitful session, and I hope we'll have some also questions and answer at the end. Please, Miss Frankie. Hello.
Thank you. Is everything coming in, and can everyone hear me?
Yes, we can.
Lovely. Well, thank you so much for the introduction, Dr. Hassam. And it's wonderful to be with you, albeit not live, but this is a great platform. And I'm glad I could be with you live today, albeit 5 o'clock in the morning. I'd like to thank the Emirates Urology Society for inviting me here today. And we'll move right along for time's sake. So I have no affiliations to disclose. And let's start with the definition of urinary incontinence. And this is as of the ICS, or the International Continence Society, who state that urinary incontinence is a complaint of any involuntary loss of urine. Now, urinary incontinence has always been very difficult to measure and define because it's not so much a quantitative problem or how much your patients are leaking, but a qualitative problem or how much it affects their quality of life. But when we look at epidemiology studies on LUTS, so that's lower urinary tract symptoms, so this includes not just urinary incontinence, of course, but your frequency, urgency, nocturia. We see 713 million males are afflicted and 901 million females globally. When we look at the prevalence rates of just urinary incontinence, again, it's higher in our females than our males, 5 to 69% in our female population, 4.8 to 32% in our male population. And in both genders, it does increase with age. We know that urinary incontinence is in fact a chronic disability for our patients that really does carry an enormous stigma. And this is because of the taboo nature of the topic. Most of our patients will suffer in silence. And in fact, the majority don't seek medical help. And studies have shown for at least up to 5 years before they seek interventions from healthcare providers. So unfortunately, urinary incontinence continues to be a significant health problem with considerable social and economic impacts. And we see how our patients change how they dress in dark, baggy clothing so they can't be discovered, as they live kind of in a constant fear of being discovered. And we also see economic impacts with loss of productivity and absenteeism in the workplace in studies done. Now, when we look at self-management strategies used for conservative measures for treating urinary incontinence, and the data, the evidence, and most of the recommendations that I'm going to be talking about today come from the International Consultation on Incontinence, or the ICI, and this was from the meeting in Tokyo in 2017. The group were meant to meet again in Las Vegas this year at their meeting, but unfortunately that got cancelled due to the COVID pandemic. So looking at self-management strategies, they include lifestyle modifications, behavioral interventions like toileting regimens, bladder and bowel retraining. It includes pelvic floor muscle rehabilitation, the use of special devices such as pessaries, mechanical devices for men, and neurotic alarms, techniques such as self-intermittent catheterization and rectal irrigation for our fecal incontinent patients, and incontinent containment products. So this is a list of conservative treatments as nurse specialists we would utilize with our patients. Some we will use alone and some in combination. And I'll try to go through each of these if we have time. So starting with lifestyle modification, and there's always been a lot of buzz, if you will, around the association of caffeine intake in increasing the incidence of urinary incontinence. But really, even though it's been very widely studied, there's conflicting evidence to support this. And in fact, caffeine intake, artificial sweeteners, acidic fruit juices, and alcohol, none of them are found to increase the incidence of urinary incontinence, even though they are irritants, bladder irritants, and act like diuretics. They don't increase the incidence of urinary incontinence. However, many of these products, especially caffeine, if taken in moderate to higher intake, will increase frequency and urgency in our patients. And of course, most of their presenting symptoms include this. So the recommendations are to try to cut back your patient's caffeine intake to at least no more than 2 cups of coffee a day. And typically, I will also try to reduce them to decaffeinated products, because in decaf coffee or tea, there's only about 3 to 8 milligrams of caffeine versus about 280 milligrams in a regular cup, dependent on where you buy it. When we look at constipation, so fecal loading pressure in the lower rectum tends to irritate the bladder and compress against the posterior wall of the bladder. So it tends to cause bladder irritation. It reduces the bladder capacity, so the patient can't hold as much urine, and it will often offset unstable detrusor contractions. There's been many studies done around constipation and its relation to incontinence, and in a large study in women, those with urinary incontinence were more likely to report constipation. Also, straining for hard constipated stool was associated with an increase in urinary incontinence in women. Now, very few studies focused on men. Now, unfortunately, there was no evidence on the effect of regulating the bowels, treating our patients for constipation, and its relevance on increasing function in the bladder and decreasing urinary incontinence. So maybe we need to work more on these areas and look at more trials in this specific area. Now, looking at smoking, studies actually have been inconsistent for the association of smoking and the increase of urinary incontinence. Even though we know nicotine is somewhat of a bladder irritant, it doesn't increase the incidence. Although smoking does tend to have, in smokers, you'll tend to see like a chronic cough in these patients, so it does tend to increase the incidence of stress urinary incontinence. So what should we do as nurse specialists? Well, encourage your patients to eat a high fiber diet, whole grain breads, whole grain cereals, fruit, vegetables, plenty of water intake, try to be active, and encourage psyllium type products such as Metamucil on a daily basis. And many of our patients that aren't able to eat the powder form, there are Metamucil pills available now. And these will help to make the stools much bulkier, much softer, easier for our patients to pass. Just encouraging your patients sometimes to take the time to toilet. Sometimes we're just too busy to go and we miss the moment. And encourage correct seating with a stool underneath the feet so that the anorectal angle is better aligned, so less straining is required. Looking at weight loss, there's multiple trials done that demonstrate a reduced incidence of urinary incontinence in weight loss in women. So anything you can do to get your patients to lose weight, to get out, to be more active on a daily basis, to look at some dietary modifications will certainly improve outcomes, because studies have shown that obese women have double the risk of urinary incontinence. Now, there are very few studies found in men, overweight men, only those with type 2 diabetes. So again, another area we need to look at for more research. When we looked at exercise, low physical exercise did predict urinary incontinence in middle-aged women and older women. And moderate activity, like walking on a daily basis, was shown to lower the risk. Now, when it came to strenuous activity, there was a bit of a gray zone, and we need more evidence and more trials done, as what we were seeing was the high impact sports, such as playing tennis and badminton and jogging, tend to increase the incidence of stress incontinence because it impacted on weakening the pelvic floor muscle. So moving on to behavioral therapies such as scheduled voiding regimens, we have bladder retraining. So this is when your patients void too frequently. They may be going every half hour, every hour, hour and a half to the toilet. So what you're going to do is teach your patients to ignore their first urge to go to the bathroom and void on their second urge, and gradually increase the time between voids. This will help to increase their bladder capacity and less their frequency of toilet visits. Now, timed voiding is for those patients who don't void frequently enough. And as nurses, I think we're not the best at this ourselves. We're too busy to go. We're in the middle of our shift and we keep postponing the urge to go. Well, in some of our patients, if they keep postponing, they have a sudden onset of urgency and often will lead to urinary incontinence. So in these patients, the recommendations are to put them on a timed voiding, starting at every 2 hours and gradually building up the intervals till they're voiding at a more natural 3 to 4 hourly regimen. Now, habit training is for your cognitively intact patients, and prompted voiding is for your cognitively declined patients. And with prompted voided, you need a caregiver to kind of prompt the patient, remind them that they need to go to the toilet to empty their bladder, and help to direct them to the toilet, because they often can't remember with cognitive dysfunction where the toilet even is. Now, all of these voiding regimens and schedules need to be patient specific. So it depends on their age, on their comorbidity, what type of leaking they have, what type of bladder problem they have. So doing a thorough assessment, including a 3 to 5 day bladder diary, is essential. Now, when we look at evidence for treatment for the effectiveness of urge incontinence, stress incontinence, and mixed incontinence, we do see some quite a bit of effectiveness in trials done in community-dwelling women to improve outcomes, even though the sample sizes were small. For prompted voiding, there was an improvement noted again for daytime urgency, in the frail older adult population in long-term care facilities, as long as there was caregiver buy-in. So they need to be enough staffing in these long-term settings to be able to give the care to their patients, prompt the patients, take them to the bathroom and helping with their toileting regimens. Now, unfortunately, there really are no prevention trials that we could find for behavioral interventions. And again, work needs to be done in this area. Moving on to pelvic floor muscle rehabilitation in women, and starting with women with stress incontinence, urge incontinence, and mixed incontinence, we found 44 trials, but unfortunately there was a great variation in both the sample characteristics and the treatment regimens, and different schedules for how many times pelvic floor exercises need to be done, the number of repeats, the length of that hold rest period. And many times as nurse specialists, what we'll do is tailor it to our patient's needs, so that it's not a specific exercise regimen that we go by guidelines. We go by, if the patient can only hold their contraction for 5 seconds, then we'll try to get them to hold for 6 seconds, rest for 6 seconds. But this made it very difficult for them to study and in a study environment and to compare these trials. But most did favor pelvic floor exercises in treating stress, urge, and mixed incontinence in these women. When we looked at pregnant and postpartum women, 2 studies showed reduction in urinary incontinence, but only in late pregnancy and 6 months postpartum. And this was with both a supervised program as well as home programs. So no long-term studies were done after the 6-month postpartum period. And again, a grey area that we need to look at more research in. Looking at pelvic floor muscle rehabilitation in women with prolapse, there was multiple trials that favored intervention, but no current evidence for prevention. So the International Consultation on Incontinence recommendations are that pelvic floor exercises can in fact improve prolapse symptoms, so more of the bothersomeness and the severity of the prolapse. And it also found that treating or trying to prevent and treat constipation is associated with the development of prolapse. So basically the main indicators for the presence of a prolapse is constipation, pregnancy, and vaginal delivery. So helping to treat the constipation was definitely helpful. Looking at pelvic floor muscle rehabilitation in men, this centered mainly around men with radical prostatectomy with stress urinary incontinence post-op. We found 58 trials done, but again, those different interventions, because every specialist would have different schedules of pelvic floor therapy, different approaches. The results were not consistent. However, it did favor that pelvic floor muscle rehabilitation did improve urinary incontinence. Now, for men that were incontinent for months to years after their surgery for radical prostatectomy, there was little evidence to show improvement in their symptoms. So for men with post-void dribble or post-micturition dribble, we often see this post-radical prostatectomy. There was 2 small trials conducted that showed either pelvic floor muscle exercise, a strong contraction, or fast twitch muscle exercises that help to kind of milk the urethra and help allow exit of that extra urine that was left in the urethral passage, did improve their post-micturition dribble. So the ICR recommendations are that in men with post-radical prostatectomy, it's best to start preoperative pelvic floor muscle therapy or immediately post-op pelvic floor muscle therapy, and that this would help to improve earlier return of continence. Now, there wasn't enough evidence to benefit that adding electrical stimulation or biofeedback therapy was beneficial for our patients. However, often I find with my patients that have had radical prostatectomy, they have so much to deal with. They have the cancer, the erectile dysfunction, and now the stress incontinence. And if I find they're not moving along well enough with their home treatment, I will often put them through a course of electrical stimulation and biofeedback of the pelvic floor muscle, and it does help to improve outcomes and speed up the process. So sometimes, even though we have to allow evidence to guide us, it's also best practice. We also found that use of a strong pelvic floor muscle contraction or fast twitch muscle contractions to help milk the urethra and allow for urethral massage to empty the urethra should be offered to prevent post-void dribble incontinence in these patients. When we looked at special devices, starting with women with prolapse and the use of pessaries, 5 studies were done. There was improvement in outcomes, both in bladder symptoms and prolapse symptoms. And there was also one study that we found to compare pessary insertions to pelvic floor muscle therapy, and there was no difference noted. So the recommendations are for pessary use plus pelvic floor muscle therapy is the best benefit, or using either of these therapies alone is equally effective. Now, typically, either the Gellhorn pessary, which is the one you're seeing here, or the ring with the support pessary are the 2 pessaries that may improve the prolapse symptoms, so the bothersomeness, the heaviness of the prolapse, and reduce their impact. When we looked at the use of special devices in men with urinary incontinence, they mainly centered around mechanical devices such as penile clamps. Now, there were very little research done in this area, so not a lot of research in this area, and they were only found to partly control urinary leakage and were also found to be painful at times. There is a caution with these devices, of course, because they could tend to cause potential tissue damage and penile ischemia. Now, typically what I do with my patients is I bring them in, I do an assessment, and if it's something I think is viable to work for them, I'll give them a choice of penile clamps, I'll tell them how to order it, I'll bring them back into the clinic and I personally fit it. I make sure it's tight enough to stop the urinary leakage when they're jumping up and down and coughing, but not tight enough to cut off the penile flow of blood or cause ischemia or discoloration to the penis. You need to make sure they are coherent, that they know when their bladder needs to be empty, that you need to be able to ensure they've got good manual dexterity to be able to open the device and close it, and they've got good vision. And so our recommendations basically center around these same concepts, that these devices can be considered for short-term intervals in select men with stress incontinence, particularly after radical prostatectomy. If the patient's cognitively intact, they're aware of their bladder filling and they can open and close the device on their own, and they should be fitted by a trained healthcare professional and reviewed regularly. So what can we do as nurse specialists? Well, educate your female patients on the use of pessaries and their supportive role in helping pelvic organ prolapse and the bothersomeness symptoms. Now, some specialist nurses are able to fit the initial pessary and able to teach the patient how to insert the pessary themselves and remove them and wash them. And if you have an older patient or one that isn't able to manage self-management at home, they need to be routinely booked in for changes with a specialist every 3 to 6 months and to check the vaginal vault, depending on the different type of pessary they're using. Now, for your patients with postmenopausal symptoms and atrophy noted, and what you're going to see on vaginal inspection is a very thin, paper-thin, friable tissue that's got quite a bit of discoloration, both in the vaginal vault, the labia minora, and within the vagina. And if you see this, what is indicated in our recommendations is to use estrogen replacement locally. This will really help with your patients to be able to insert the pessary with much greater ease and much more comfort. Typically, I would suggest 1 gram of premium cream intravaginally, or if your patients find that too messy, there are other products similar to Vagifem, which is kind of like a tablet they insert into their vagina, and again, twice a week. For your male patients, it's recommended that a specialist nurse help to fit the first clamp to ensure that urine loss is controlled, but the blood supply to the penis is good. Moving on to percutaneous and transcutaneous tibial nerve stimulation. This is used for our patients with overactive bladder symptoms and urge incontinence or mixed incontinence. It involves placement of either cervical electrodes, as you're seeing here, for the transcutaneous tibial nerve stimulation, or needle electrodes with a 34 gauge acupuncture needle, which is placed proximal to the tibial nerve, which is cephalad to the medial malleus. For our patients, that means we teach them how to find that magic spot approximately 3 finger breadths above the ankle bone. Now, when the electrodes are placed, or the needle electrode is placed in this area, it creates an inhibitory effect by stimulating a large diameter of somatic afferent nerve fibers, and therefore it inhibits overactive bladder activity. And if you've ever seen young children, or actually even your adult patients, kind of dancing up and down on their toes, basically that's what they're doing too. They're overstimulating the tibial nerve, synapsing at the pelvic nerve, and settling down that overactive bladder contraction. So studies showed 3 trials that percutaneous tibial nerve stimulation, in particular one was very large study, it was well controlled, and there were 2 small pilot studies that did improve outcome in urge incontinence and overactive bladder symptoms. Now, neuromodulation in the form of sacral neuromodulation can also be used. And this is similar to like a bladder pacemaker, if you will, that's inserted on a semi-permanent basis after a trial period, left under the skin by the sacral complex, and exerts a continuous stimulation to the bladder, and has also been found to be effective. So the recommendations are in adults with urge incontinence that percutaneous tibial nerve stimulation is certainly better than no treatment at all, and can be used as an adjunct with our other behavioral and lifestyle interventions. Typically, I would use all of these recommendations prior to looking at drug therapy. When we look at incontinence containment products, there's a plethora of absorbent products on the market today, and there's really no single best design. It has to depend on your individual patient assessment, what their age is, how mobile they are they in a wheelchair, are they in a long-term care facility and need a caregiver, or are they independent at home? What type of incontinence do they have? Do they have just stress incontinence, which is minor? They might just need like a very thin liner, or do they have urge incontinence with a full leakage episode of bladder contents where they'd need a more absorbent product done? So assessment is vital when looking at containment products. Also, the fact that there's different products for men and women, and many men especially don't realize this. So our recommendations are that gender should always be considered when prescribing any products, and sometimes a combination of designs may suit your patients better. For instance, they might like a disposable product for the daytime, but like something that they can wash and save costs, like bed liners and protectors at nighttime. So just looking at your patient's needs and the cost effectiveness of these products. So the end of my talk is basically going to focus on catheters, and I know you have a workshop after I leave today when I'm going back to bed. I wish I could be with you and see what you're all doing in your different countries and share your experience, but I think this would be a good introduction for you. So starting with indwelling catheters, the indications for their use are only to monitor your acutely ill patients for hourly output, to manage your terminally ill or severely ill for end-of-life comfort, for short decompression for acute urinary retention, and only until that acute stage has been treated. Then it should come out. It can be used only to manage urinary incontinence in your older patients with stage 3 or 4 pressure injuries, and only until that pressure injury has been treated, then it should come out. It can be used for bladder obstructive outlet, like your benign prostatic hyperplasia, urethral stricture, your bladder neck contracture, until that has been treated or until your patient's able to manage intermittent cath themselves. It can also be used in neurogenic patients like your multiple sclerosis, Parkinson's, spinal cord injured patients, only if they're not able to manage self-catheterization due to bladder spasms or poor manual dexterity. Now, the contraindications for using indwelling catheters, they should never be used for urinary incontinence that's not associated with a full thickness pressure ulcer. They should also never be used if pelvic trauma is suspected, because you may have a partial fracture of the urethra, and passing the Foley catheter may completely fracture it. So intermittent catheterization is certainly the choice of treatment. Typically, the patient catheterizes themselves 4 to 5 times a day or every 4 to 5 hours using a clear PVC catheter. It should have nice polished eyelets, and a nice rounded tip. The patient needs to be taught the technique first, and then made sure that I usually tend to watch over them and make sure they can manage their technique well. They need to understand that the safe volumes are each time they catheterize. They shouldn't see much over 500 mils of urine or catheterize any more than 5 times max a day. If the volumes are higher or they're catheterizing 7, 8 times a day, then they need to have some fluid advice and restrict their fluids more. Typically, they should be assessed urodynamically if they're a spinal cord injured patient, and functionally with a bladder diary for all your patients that are on intermittent catheterization. And they should all have routine follow-ups with both yourself and their healthcare provider. Now, there are many different catheters on the market today. There are uncoated catheters where the patient puts a mucoid jelly on the tip of the catheter and inserts the catheter, or there's hydrophilic coated catheters, and this is a hydrophilic coating along the length of the catheter. There are different coatings too. There's antimicrobial coating, there's antibacterial coating, but we don't see these used as much as the hydrophilic coated catheters. Now, hydrophilic catheters can reduce long-term urethral complications such as urethral trauma and reduce friction. So they can and have been found actually to reduce the incidence of urethral strictures by reducing inflammation. They can be used, and I use them a lot for patients that find it uncomfortable during catheterization, and they're much easier to insert. And some of these come also with a no-touch system, so that their hands never actually touch the catheter. Now, for your indwelling catheters with a hydrophilic coated lining, they're known as hydrogel coated latex catheters, and there were studies that showed their risk for earlier removal was much lower with the hydrogel coated catheters rather than the silicone catheters. Now, I just want to take a minute to go over a Cochrane review from 2014, and this was from a group of very well-known researchers that had been working in the field of intermittent catheterization for many years. The objective was to compare intermittent catheterizations, both the materials, whether they were PVC or rubber, the technique, whether it was an aseptic versus a clean technique, single use versus multiple use, self-catheterization versus caregiver catheterization, and cost effectiveness. The selection criteria included all randomized control trials that had to compare at least 2 different catheter both designs or 2 different catheter techniques or 2 different strategies. Now, at the time, the opinion that was expressed in this review really had a strong influence, as most of us as healthcare providers in the field and agencies, and some of the recommendations suggested reuse of catheters. There was no increased incidence of UTI in these patients. Now, in 2017, a group of researchers conducted an independent review of this data and a complete analysis, and the appraisal identified identified, four crucial discrepancies in data extraction and the analysis within that Cochrane review. After addressing their concerns to the Cochrane's acting editor-in-chief, the most recent version of the 2014 Cochrane Review was withdrawn from publication in 2018. And the article is, as you see on the screen, the devil is in the details, if you want to read this article. So clean intermittent catheterization basically is a very effective technique with very low side effects. Strictures are rare, both urethral strictures and meatal strictures, but they can be seen, especially with prolonged use. We see less strictures with hydrophilic catheters, so if they can afford it, it's probably best to suggest these. Epididymitis and orchitis are very uncommon in less than 5% of our patients. Urinary tract infections can occur, but much less commonly than with your indwelling catheter. An indwelling catheter left in for a month has almost 100% chance of bacteremia, whether a one-time insertion with an intermittent catheter has less than 1% chance of bacteremia. False passages, such as you're seeing here, are rare, especially in sensate individuals, but they can occur when the patient is inserting the catheter and tends to dig in what we call a false passage because they can't get past their urethral stricture. So they can occur. So there is a higher rate of catheter-associated urinary tract infections with indwelling catheters versus intermittent catheterization. And this is due to biofilm formation and the increase in bacteremia. So our recommendations are that intermittent catheterization is the treatment of choice for ongoing bladder emptying and for high post-void residuals, and indwelling catheters should only be inserted as a last resort in management with urinary incontinence. External catheters, like you're seeing here, is an option to treat urinary incontinence, but only in those patients that are able to empty their bladder. They're put over the penis in our male patients and attached to a leg bag for intractable urinary incontinence. So we have to ensure they're able to empty their bladders. So what can we do as nurse specialists? Well, if at all possible, remove any indwelling catheters, replace it with the intermittent catheterization technique, teach the patient how to do the procedure first, and then have them repeat the procedure back to you. Ensure they have good vision, good manual dexterity so they can manage at home independently, and ensure they understand the treatment regimen, when they need to catheterize, how often they need to catheterize, and follow up with them on a regular basis. And hopefully I've left lots of time for you for questions, and I'd happy to take any from you at this point.
Thank you so much, Frankie, for this really very fruitful and this great insight in a very rare specialty, I have to say, for being a nurse specialist in urology. And especially in the Middle East, this is just some new concepts, the nurse specialists that are going in. We have started in the Middle East, the wound care specialists. We started some hospital diabetic care specialists, but urology nurses, specialists specified in this area, this is really a very, very new area, an era in the whole region. It was really, I enjoyed it a lot. But what actually struck me, Frankie, is there is very little and limited research and evidence, and the area is really full and rich still of possibility and potential of doing more studies. Do you know why is this? There is not that much studies. I mean, there are huge gaps when it comes to behavioral intervention studies, or sometimes the studies has focused on male or female. So you find more studies on male, but you don't find this. Can you explore a little bit on that?
I think a lot of the time as nurses, we don't think we have a role in research. where we probably can and should, something as easy as looking at a bladder diary and, seeing how fruitful a bladder diary can be, how well it can help with our diagnosis and prognosis and treatment modalities. Sometimes I think we undermine ourselves and think, well, this isn't worthy of a clinical trial. And
Yeah.
all we need to do is get out there and look at a question that we all might have, is pelvic floor exercises more fruitful and beneficial to our patients, preoperatively, before a radical prostatectomy, poses, 1 year post op. Sometimes a simple study is very fruitful when we're looking at evidence-based nursing management. And so I think, we look maybe more to the physicians to look at research, whereas we're very capable of managing those ourselves and getting some of the answers that we want.
Definitely. Any of the, because I have nothing on the system questions and answer. I got a few questions, but I think I will leave also for the table for the attendance. Any questions? Anyone would like to ask anything? Okay, I have actually also a few questions when, you explained, because those are, I think, all new to us. Tibia, when it comes to tibia stimulator, tibia nerve stimulators, from your own experience, are they effective? And how do you actually use them? Because, I mean, I haven't seen them here in this region.
Yes. So years ago, we started off with the percutaneous stimulation proximal to the tibial nerve. But what we found and what we were concerned about is the scarring at the area where we were inserting the 34 gauge needle. And this was a SANS, stolar afferent nerve stimulation therapy. It was very beneficial. However, we found that using tibial nerve stimulation was just as effective. And I think when the ICS was in Egypt, our center had a abstract that showed the indication that tibial nerve stimulation was actually just as effective as percutaneous tibial nerve stimulation.
Yeah.
So what we do is we use, basically it's a TENS machine, and we have 2 surface electrodes, and one is placed proximal to the tibial nerve, which is your 3 finger breadths above the ankle bone, on the inner side of the ankle bone. The stimulation is applied for 30 minutes, and basically it stimulates up the tibial nerve synapses at the pelvic nerve and settles down those overactive bladder contractions. Typically, we bring our patients in for weekly treatment until they're able to find that magic spot, and then we get them to buy their own device. It's not an expensive treatment modality to purchase, about $100 Canadian, and we get them to do home treatment, typically once a week, or they can go up to twice a week, sometimes even 3 times a week. And it really has been found beneficial, especially when we look at symptom scores, the ICIQ scores, the bladder diaries, that we see an improvement in both nocturia, with frequency, with urgency, and with quality of life issues with this treatment. And oftentimes they can come off their anticholinergic medications. So we use it quite a lot in our center, and we found it extremely beneficial.
Thank you. Another question is, just would like to ask about indwelling catheter. You mentioned about, because there's always been debate, and I've been involved also on the same debate when it comes to indwelling catheters. There are some antibiotic covered tip, some silicones, some are rubbers, and all that. Are the antibiotic, are they covered, the one that's basically antibiotic treated, or they are covered, are they any better than the silicone one in your experience?
I'm not sure of the answer for that, really. Any indwelling catheter isn't the best.
Yeah.
So, I know like the silicone catheters and some of the non-latex and some of the hydrophilic coated catheters are better tolerated for our patients. But basically, every catheter that's in situ for a month has bacteremia. We know that. Whether it's going to cause a symptomatic bladder infection in our patients, of course, is something else. So the best indication I can give you is if you can get the catheter out of the patient and teach them intermittent catheterization, that's best evidence, best practice. And of course, I would say that probably the latex catheter any long-term catheter should always be removed as soon as available. Try to do a trial avoid and get that catheter out.
Yeah, just the last questions from my side when it comes to intermittent catheterization. I think in the region, in the Middle East region in general, you know, the most of the patients that use this are patients with spinal injuries due to road traffic accidents and increased volume of road traffic accident, unfortunately. You have set many strategies, and are they going, I mean, like when you mentioned different, you know, when it comes to behaviors, when it comes to equipments, I presume, you know, the approach will be different with different cases and reasons for it, yeah?
Definitely, definitely.
That's the most is spinal injury, to be honest, are the patients that we have, or stroke patients with CVA. Yeah.
Definitely. And, you know, we see a lot of spinal cord injury patients. We have a center here in my province. Usually they manage catheterization routine extremely well, as long as they have good vision, good manual dexterity, and just sitting down with them, explaining the safety of the procedure and watching how they perform the procedure. Are they safe to go home? Do they understand the procedure and how often to do it, and how to limit their volumes of intake if they have huge volumes of bladder output, and just showing them different types of catheter. You know, a hydrophilic coated catheter is much more comfortable perhaps, and just using different techniques. There's different devices that you can use for your patients, you know, that may not have the good manual dexterity that enable them to put the catheter in. Sometimes teaching the caregiver to catheterize, if they don't mind, that is an option too, if they haven't got any manual dexterity at all, if they're quadriplegic. But just bringing your patient in, explaining the procedure, explaining the safety of this procedure versus an indwelling Foley catheter. And once they've tried it a couple of times, it's surprising how they buy in. They really do buy in. And there's a plethora of different catheters on the market now, and it's not one catheter suits all. You know, you need to kind of tailor it to your patient's needs.
Yeah, thank you so much. I think we are done now with the time. It was really an honor meeting you, and this is really, I think we have enjoyed it a lot, and that was great information, and we really appreciate so much wake up at 5 o'clock in the morning and giving us the time just to enlighten all of us. Thank you so much for that.
You're
Frank.
welcome. Enjoy the rest of your day.
Thank you. Bye-bye.
Bye-bye.
Bye. Okay, guys, thank you so much. I hope you enjoyed it. There will be a 15-minute session that will be led, I think, by one of our nurses in SKGH, and also another person from the company, I think. They will be doing it. It will be on site here, just hands-on, 15 minutes short before we conclude the day. Thank you so much, guys. Thank you.
Hello guys, can you please come over? Yeah. Yeah, the other table. Yeah, just next to it. Next to it? Yeah.
Basically, I know that some of you experience patient with urinary incontinence, and very rarely that most of them are male, but very rarely are females. So today, I'm going to focus on female patients who are the first timer in using intermittent catheter. So 1 year ago, there was one patient referred to us by the ward telling us to teach the patient how to insert intermittent catheter. So as we all know that prior to teaching the patient how to insert catheter, intermittent catheter for the first time, and it's a teenager, you have to assess the patient of the psychological and social assessment, either for the caregiver or the patient itself. Because we have to understand that we are in an Arab country and the stigma for having this kind of disability is so high that sometimes most of them refuse to seek treatment because of the embarrassment. So we need to assess them of the readiness to learn how to do intermittent catheter. Okay? So first, we emphasize the importance of hand washing to the patient prior to doing any of the activities. And for the first timer, we normally do first a review of the anatomy of the urethral organ. So in female, there will be 3 holes. Up is the urethra, second is the vagina, and third is the anus. Okay. So we want them to familiarize this area here so that when they start to practice the procedure, they get the idea and the familiarity of their organs. Secondly, we usually give them the accountability to own the power to take responsibility for themselves. So you have to ask the patient first if they are comfortable having their parents around, because most of our patients are teenagers and they are not comfortable with their mother coming around in the toilet or their caregiver. Sometimes they want to just do it with you alone in the toilet. So you have to ask them, are you comfortable with your mother around, or are you comfortable with the caregiver with you? And they said, no, I just rather be with you. So first and foremost, we will go to the toilet, emphasize the hand washing technique. Of course, it's very important, and teach them how to clean properly this area here, from front to back. Okay, front to back. Now, there are some wipes that is newly introduced to us by my colleague. It's a hexacath, right, with chlorhexidine 0.1%, and that's a very good idea for those students who are on the go and or they're just roaming around with their friends and they are in the mall, so they can use it because it's very inconvenient in a public toilet to wash their private area. So that hexacath actually is a good idea also to introduce. Now, after teaching the patient to wash their urethra and their perianal area, then we will ask them the options of which of them are comfortable to insert the catheter. So there are 3 methods actually that I know, and it's widely practiced in European countries. Some of the patient would like to sit on the floor with mirror so that they can have vantage point of the visualization of their urethra, so they know where's their urethra. The other one, they just sit on the edge of the toilet seat, and then they will put the mirror in the floor, okay, so they can visualize their urethra also. And the third one, they will just sit completely in the toilet bowl. And this third one actually is for those expert already. They know how to to do it by their own selves. So it's for them. Some other patients are bedridden patients, so they need a caregiver to do it. And if they cannot find it and they want to do it on themselves, they can also use mirrors to insert the catheter. Now, in the urology, mostly this product actually here is for illustration purposes only, but we are introduced, some of the patients are using this product. So after cleaning this one, then we will instruct them on, we will first guide them how to insert it. Okay, so
Fine, I'll show hands-on training after she gives the presentation.
Yes.
But just come over because I cannot show you everything while I'm holding the.
You can have one and you can try, you can pick some,
I have
these.
to show first hands-on Are you there?
Yeah, no, not yet. So,
I'll show you how to open.
oh, okay. But you can have one in case it
Yes,
when
everyone
she's
has
giving the
one.
lectures.
Yeah.
So,
Full portfolio.
so unfortunately, this mannequin here cannot retract the labia. So I just have to show it to her that this is the proper way to insert slowly and gently towards the. She has to insert it slowly and gently in the urethra. Just take note that some of the patients here have a congenital anomaly, and there are sometimes multiple false passage in the area. So it's very important, especially to those patients, that they have to familiarize which one is the true one. Okay? So you instruct them to slowly insert it gently in the urethra. Then once there is a drainage of urine, you can just lower down the funnel of this catheter and insert it a little bit more, like 1 inches more, and then just lower it down and drain the urine. So once she's finally like she feels like it's already empty, then she can gently withdraw it. But on the way of withdrawing, if it's still there, if there's still a urine, then she can just wait for a few minutes till it's over. Then she can finally withdraw. And sometimes they have to make sure that it's already empty, so they press the bladder here in the hypogastric area. So they're pressing it so that they can fully empty the bladder in this area. Now, so she can throw it anytime after using and dispose it in the toilet, the trash bin. Now, what we really encourage for those teenagers is that they have to prepare a pouch whenever they go anywhere. So a pouch with several of these items, with hand wipes, with alcohol gel, and some disposable bag for them to dispose, because some areas here are, I know that areas here in UAE is toilet is very accessible, but some other countries it's not. Okay, so we normally ask them to prepare this one, several of these items. And just to emphasize also for them that every time they made mistake or they put it in a different hole, or it touches on their skin, they have, or hands, they have to discard it immediately so as to avoid contamination or UTI. Okay, so it's very important for them to know that this, just to prevent infection. Now, apart from that, there's another type of compact catheter with urine bag. This is very good when they are traveling, or when they are in rural areas where access to toilet is very limited. So she will give you further details on what is the type of this compact catheter, but I'll just show it to you that this comes with urinary bag. And it's also good for the wheelchair-bound patient and those that are bedridden, because you don't have to prepare everything, and then it's all comes in one package. So also we encourage the patient, if they are traveling outside or abroad, when they are in the airplane, to use this type of catheter. Okay, if there's any question, you can ask me.
So I'll first introduce myself. My name is Nihal from Coloplast. I'll show you now all the full portfolio of our SpeedyCath catheters. I know the social distance is an issue, but if you can just gather, because I cannot show the whole side. My voice is loud. So as Sister Cherry, first, for the females, we are having this unique, discrete design for SpeedyCath compact. We took everything, yes, it's fine. Then when you start opening the compact, this is the drainage part, upwards, it has to be upwards, and the cover downwards, okay? Then you twist both sides, and then when you hear a click, you take it out. Okay, I have a question. Yeah. Yeah, it's okay. Okay. So I have a question, please. How long is the female urethra? Ah, I'm that much popular. How long is the female urethra? Female urethra. Huh? It's not working. So it's from 2 to 5, around 2 to 5. Okay. So when I give a female or a girl or a lady a catheter which is 7 or 9 centimeter long, is that okay? So it's fine. So we don't need to go for the standard, the 20 centimeter anymore. It's fine if it's 2 to 5 centimeter long. We offer a compact, discrete design, 7 centimeter or 9 centimeter. That's fine. Yes. Okay. So as Mrs. Franklin mentioned, what are the 2 main points she was speaking about for the intermittent catheterization? If you remember. I remember. Okay, she mentioned the coating and the islets. Yes, our full portfolio of SpeedyCath is uniform hydrophilic coating catheters and polished coated islets. So when we speak about SpeedyCath, either the standard, which is the 20 centimeter length, or the compact 7 centimeter length, or the other compact plus 9 centimeter length, or the male portfolio SpeedyCath, we are speaking about the same features, which are uniform hydrophilic coated catheters and polished coated islets. Okay, why are those 2 are important? Again, as Mrs. Frankie mentioned, I was alone attending. Okay, she mentioned, I was so alone attending. Okay, she highlighted 2 main things. The trauma damage, damage of the urethra or urethral trauma, and UTIs. So minimizing UTIs, minimizing any urethral damage, we have to have a uniform coated catheters and polished coated islets. Okay? So, moving forward to the designs. For the females, we are having the compact designs, discrete designs with very hard handling so they can easily insert and withdraw. Okay? Compact. Then, the compact set, as Sister Cherry mentioned, it's the all-in-one product for females who are not having an access to the toilets. All-in-one. Discreet, compact, easy to use, with urine bag. Integrated 750 milli integrated urine bag. Okay? So what do you think about this compact portfolio for females? If we imagine how the female who is having a neurogenic bladder feels, especially if she is mobile, if she's going to school, a girl, or she's going to work. How do you feel? How do you think? Is it really beneficial for those? Okay? Okay. Yes. Convenience. The convenience. It's already a very tough lifestyle. So the convenience is very important. Then goes to the males. You know that the percentage of males with neurogenic bladder are much higher than the females. Then again, we will not speak about the features. It's a SpeedyCath. Okay, standard. The standard catheters, Nalaton tip. Okay, but again, we are speaking about the uniform coating with the polished islets and ready to use. Yeah, I forgot to mention the most important part about this because I was focusing on what Mrs. Frankie mentioned, the 2 points here and here. But for our full portfolio of SpeedyCath, it's a ready-to-use catheter. You don't need to activate and you don't need to lubricate. You just open the pack, use, finish, discard. It's environment friendly anywhere. Okay? And the focus comes to the SpeedyCath Navi. Okay? The SpeedyCath Navi. Okay, it's again a SpeedyCath with all the features that we mentioned, but there are 3 more advantages over what all we said in this product. Okay, for males. First, it's a softer catheter than all our previous versions. It's a softer catheter. Second comes the insertion whip. The insertion whip is for a hygienic stepwise insertion because it's not a regular whip, it's a pinchable whip. You can pinch, you just release it from the connector, 2/3 of the catheter, then you pinch and you stepwise insert till all the bladder is empty, then again you discard it. Third is the flexible tip. Actually, the flexible tip is the first. We have to speak about it first. The flexible tip. The flexible tip, omnidirectional tip, it can goes and navigate the male urethra with all type of male urethra with all type of challenges, strictures, enlarged prostate, whatever the challenge. So all males with all the challenges can use the Navi with all the comfort. Okay. So Speedica standard, Speedica Navi. Okay. My voice is clear because I'm moving. It was clear? Yeah. Then again, the compact portfolio for males. Okay? I have a question. This is the 5th question and nobody answered. I'm the only one who answered. Yeah. Okay? How long is the male urethra? You know the female, you know the male. Any answer?
Times 2 of the female.
Yes.
Double the female size.
How long was the female?
Longer than female.
And we answered and we don't remember.
Maybe 3-fold.
Okay. From 15 to 20 centimeter long. So when we speak about the standard portfolio, which is 40 centimeter, okay, it was long enough. The 40 centimeter, the standard portfolio of intermittent catheters as general. And here comes the compact design for males.
Very long.
Okay, no, it's 30 centimeter compact. 30 centimeters. So 30 centimeters for males whom urethra size or length from 15 to 20. The compact would be
30.
again perfect for use. Okay. How Coloplast went for a compact design? It has to be a telescopic way. So I can put it here in this hard cover. Yeah. How? See how? So to compact a 30 centimeter catheter in this cover, I have to go for a telescopic design which starts from 12 size and it ends 18 size. Okay, so we have only one product, compact for males with all sizes. Any comments? Because I know there are comments. So comment. Comment.
It will
This particular catheter is includes from 12 to 18 Frenches.
Yes.
Like in the beginning, we are using only French 12
Yes.
for the patients. Okay.
Yes.
So this length for a male,
Yes.
at least the standard size,
Yes.
is 12 to 20. Okay, we start with 12.
Yes.
It ends with 18.
Yes.
Of course, patient will feel discomfort when they will reach the 18.
Okay.
And if we are not able to insert until the 18th French, the urine will not empty from the bladder.
Okay.
So what's your comment?
Can I ask you a question? The challenge is in the again, and nobody answering. Nobody's answering. When is the challenge exactly? When? The challenge is when you first insert. Then because the user is not phobic of the length or the size, he's phobic of the process itself. So if he feels that it's inserted, okay, then he will be already relieved. And he will not feel anything except that he wants to find the urine coming out of his bladder. So the insertion starts with 12 till here. and he will not go for that long, because once he sees the urine going, he will be very relaxed and comfortable. And then, you know, everything in the world, when you get used to it, this is 4 to 6 times according to protocol. And I'm already having in UAE like 10 to 15 users on this. They have no issues. But you speak, if you use it, if you dilate, or you speak about he is self-catheterized. Self-catheterized, I have many like good feedback. Many good feedback about the compact.
Range 18.
But
Okay.
for males, they are going for 18.
It's not for the first time. It depends. If they are the chronic user, long-term user, yes, they can go up to 18, not from the first attempt.
Okay.
It will take a long years.
Yes, yes. Then this compact portfolio is not for the first time.
First time.
For the lifetime use.
Yes.
Because you know, the urgent for other users are on this lifetime. So it's not only first time.
That's why I'm telling.
But that's why Coloplast is having the whole portfolio. Because whoever wants standard, there is. Whoever wants compact, there is. Whoever wants compact set, there is. The Navi, which is the best option for males, is there.
Nihal, what she's trying to say is that for the first time user, I didn't think that it's ideal for them to
Yes.
use the compact because
Yes.
they experience hematuria and pain.
Yes.
Thank you.
But for the long-term
I
user,
thought you are speaking as general.
No.
for the long-term user, yes, it's
Yes,
very
and
ideal
of course
for
you
them.
guys are experts with the direct, relation with the patients and the users, so you will know.
Because I know very well we got the feedback from the patients, especially when they use.
The compact in the clinic. She knows, yeah, exactly. So,
Thank you.
Yes, thank you so much. Everybody knows about this point. If you want to share it, I don't know, they're not, it's fine. That's it. So any other questions? Now you can have one piece from each, because now you know how you can open it. No, if you want to discard, sir, you just put it back in place, but you cannot reuse because it will be spoiled. And the whole compact is having, and whole cutter are having sterile saline inside. So take care when you open, so it will not pour in your clothes. Okay? Thank you so much. Everything is clear? Thank you.